which is normal. In thinking about Miss G's infection risk and immune system, as I previously mentioned, Miss G's white blood cell count was 12.4, which is high. So I came up with a nursing diagnosis of risk for infection related to being in an immunocompromised critical condition as evidenced by elevated white blood cell count. The goal for this nursing diagnosis while caring for Miss G was that she would not acquire hospital-associated infections during her time in the hospital. The nursing interventions used to achieve this goal were bathing Miss G twice a day with chlorhexidine wipes to decrease risk of MRSA or VRE in any lines such as peripheral lines and arterial lines, frequent oral care and suctioning, maintaining the head of the bed of at least 30 degrees or higher, and providing frequent Foley care with mild soap and water. In Miss G's current condition, hemorrhage versus clotting is a very important part of her care, and the nursing diagnosis that best fits her situation is risk for bleeding related to possible adverse effects of anticoagulant therapy as evidenced by a patient having received TPA. The goal for the nursing diagnosis while caring for Miss G was that she would not develop a bleed intracranial or anywhere else. The nursing interventions used to achieve this goal were every 15-minute neurochecks, and protection of her PICC line and her peripheral IV sites. Due to Miss G's difficulty maintaining oxygenation and perfusion, I felt these nursing diagnoses applied to her. Ineffective cerebral tissue perfusion related to decreased oxygen to the brain as evidenced by an ischemic stroke. Ineffective airway clearance related to inability to know when to clear the throat or swallow adequately as evidenced by pooling of secretions in the back of the patient's throat requiring suctioning. Ineffective breathing pattern related to a patient's attempt to adequately oxygenate her body as evidenced by increasingly high respiratory rate. The goal for these nursing diagnoses was that Miss G would remain adequately oxygenated and perfuse her core and extremities by maintaining an O2 saturation of at least 93% or higher. The nursing interventions used to achieve this goal were to keep the head of the bed at least 30 degrees or higher to help ease respirations and prevent secretions from pooling in the back of her throat and affecting her airway clearance. Maintain oxygen by keeping O2 by nasal cannula on patient and preventing her from pulling it off during her agitation. The nursing diagnoses I found related to Miss G's mobility and body alignment include impaired mobility related to decreased level of consciousness as evidenced by inability to move extremities on command. Risk for impaired skin integrity related to immobility as evidenced by patient being unable to get out of bed. Risk for injury related to inability to protect herself from falls or injury as evidenced by inability to purposely move extremities or follow commands. The goal for these diagnoses was that Miss G would remain in proper body alignment in bed and free from injury. The nursing interventions used to achieve this goal were protecting Miss G from injury by keeping the bed in its lowest position and the side rails up, maintaining proper body alignment by keeping the patient aligned with pillows and support devices while she was in bed and unable to move herself, turning the patient every 2 hours and making sure she is dry with no wrinkles in the sheets. In considering Miss G's nutrition and elimination, I found these nursing diagnoses applied to her. Bowel incontinence related to decreased level of consciousness as evidenced by inability to control bowels or realize when she has the urge to have a bowel movement. Risk for unstable glucose level related to critical illness as evidenced by increased glucose levels. The goal for these nursing diagnoses was that Miss G's blood glucose level would be controlled at an adequate level with insulin if necessary, and she would be changed in an appropriate amount of time when she becomes wet or soiled. In assessing Miss G's pain, Miss G was unable to express if she was in pain due to her dysarthria. However, her agitation and restless state suggested she may be in pain, so Haldol and Presidex was given to help calm and relax her. The goal in relation to Miss G's pain was that she would not report or to be in any pain during her time in the neuro ICU. The nursing interventions used to achieve this goal were to keep the patient comfortable as possible by keeping her clean, dry, turning her every 2 hours, and providing frequent suctioning and oral care. In relation to Miss G's growth and development, her being a 74-year-old woman, in using Erickson's psychosocial stages, Miss G was in the ego, integrity versus despair stage of her life. The nursing diagnosis I created of Miss G pertaining to her growth and development was risk for delayed development related to poor organ oxygenation as evidenced by decreasing oxygenation saturation. Impaired verbal communication related to decreased cerebral oxygenation from patient's ischemic stroke as evidenced by patient's dysarthria and decreased level of consciousness. While working with Miss G, the patient-centered goals included assess patient's urinary output every hour, control patient's dyspnea at rest, monitor patient's pain, and keep any verbalized or non-verbalized pain under control, provide fluids and medications as ordered to help patient become hemodynamically stable, keep patient's O2 sats above 93% as ordered, maintain patient's skin integrity, prevent infection, educate family on patient's condition as her condition changes, alert MD of any unexpected changes in Miss G's condition, especially in neural or vital signs that would indicate a declining condition or possible bleeding on the brain, which is a high-risk possibility after receiving TPA. On March 27th, Miss G's assessment was as follows. Vital signs, temp 99.8, heart rate 88, respiratory rate 34, blood pressure 182 over 100, pulse ox 96% on 4 liters nasal cannula. We were unable to assess her pain, although she was still extremely agitated and restless. Miss G's level of consciousness showed that she was unable to follow commands, unable to perform hand grips, she was not opening her eyes, and her right pupil was sluggish compared to her left pupil, which was brisk and reactive to light. Post-TPA, Miss G's NIHSS score on March 27th was now at 22, which indicates a severe stroke, meaning that her condition was deteriorating. The follow-up CT scan that was performed on March 26th at 16:10, 24 hours after Miss G's receiving TPA, showed a very large left MCA or middle cerebral artery territory infarct area that involved large portions of the lateral left temporal, frontal, and parietal lobes, as well as extending deep in the white matter and basal ganglia. This CT also showed a mass effect with sulcal effacement and compression of the left lateral ventricle, as well as left to right midline shift, which measured 3 millimeters. This led Miss G's doctor to be suspicious that this represented a hemorrhagic transformation in the brain, as the previous CT had been negative and all of these findings were a change from TPA administration. A chest x-ray had also been performed on the 27th, which revealed mild diffuse interstitial opacities, likely representing interstitial pulmonary edema, and slight cardiomegaly was found. On this day, 1 day post-admission, Miss G was having increased difficulty breathing and clearing secretions. Her lungs are now having loud rhonchi diffusely, and her O2 sats were dropping. Therefore, she was intubated. On March 29th, Miss G's ABGs revealed an acid-base balance of pH 7.51 high, which was signifying alkalosis, a PCO2 of 35, which was normal, a PO2 of 98, which was normal, and a bicarb of 28, which is high. These ABGs are somewhat expected as Miss G's respirations have been increased, allowing her to blow off too much CO2, resulting in an alkalotic state. On March 30th, during the next few days when Miss G was not my patient, Miss G's NIHSS score were as follows. 18, which was a moderate to severe stroke. On the 31st, her NIHSS score was still an 18, and on April 1st, her NIHSS score was a 22, which is indication of a severe stroke. These NIHSS score trends represented a poor prognosis of Miss G as her condition was declining instead of improving, representing an irreversible damage to the brain. After going back on the unit after a few days off, I learned Miss G had been admitted to a step-down neuro unit to wait on hospice for end-of-life care, as she was experiencing respiratory failure and was no longer responding neurologically, as she was no longer following commands, opening her eyes, or responding to voices. She died before hospice arrived, on April 4th at 10:30 a.m. with her family in the room. That's all. Thank you.